We welcome you all to Talk the Talk. My name is Janine Steen.
And I'm Tony Ann Antoniato.
The Masters of Myofunctional Therapy interview physicians and dentists on Long Island so you can learn how their services can benefit your child's speech and language development and complement the therapy that they are receiving.
On this episode of Talk the Talk, we are joined by Dr. Stephen Lucarelli and Dr. Joseph Barisi of Lucarelli and Barisi Orthodontics of Mineola. Thank you both for joining us today.
It's our pleasure.
So one of the questions we're often asked by patients, especially and the parents of our patients, especially when we make recommendations for orthodontic care, they typically ask at what age should their child first go for an orthodontic consultation?
Okay, typically, we recommend that our patients be seen at around 8 years old. We rarely do anything before 8, and that's really a great time for us to do our initial consultation. I will say that probably 80% of all 8-year-olds need absolutely nothing, and that we're just checking to make sure that they need nothing. The majority of our patients start treatment at around 12 years old.
Okay.
So 80% of them get nothing. We take a look, we may take an x-ray, and then we'll follow up maybe 6 months later, a year later, and just keep them on recall until there's an appropriate time to get started. 20% of the time, it actually is really important to do early treatment. And early treatment might be a palate expander, it might be, an overjet correction. Generally, it's to correct the jaw relationship or the skeletal relationship. We're not moving teeth around. That's something we can do later on. And the good news about seeing an 8-year-old is that there's almost nothing that we can't fix when we see a patient that young. The bad news is that probably 90% of all patients that get treated at 8, and we consider that to be a phase 1, probably 90% of them go on to having a second phase of treatment. So we're not avoiding future treatment. We're just doing what we need to do at that particular time because we really want to make sure that the skeletal relationship is appropriate. So I feel as though sometimes phase 1 is kind of overdone.
Mm-hmm.
And anytime that we can put treatment off and do it in a single phase of treatment, I think that we're providing a great service that way. But on certain occasions, maybe 1 out of 5 patients really would benefit from it. And really it's helpful for their growth and development.
Sometimes that first visit is just a referral to you guys for myofunctional therapy. If we catch something early on, maybe they've never even seen a speech therapist or thought, well, we don't have any speaking problems, so why, go to a speech therapist? And we have to explain that, there's a habit here. Typically, it's a tongue thrust. 8 years old, they're typically kind of young. We're very conservative in terms of our orthodontics. Most of the time it is a palate expander if we are going to do a phase 1, but it's really great to have a young kid, 8 years old, get them used to coming into the office, see what we do. Nothing hurts. It's very comfortable for them. It's an environment that hopefully they're happy to be in. And we do growth checks. So we see them every year or every 6 months for the majority of the patients that we're seeing. And we're watching them grow up and making sure that everything's developing properly. And sometimes maybe after that first year or 2 of observation, okay, maybe a phase 1 is warranted because something changes, but at least we're there to catch it early and, take it from there.
How does a fee structure work with consultations, especially if parents want to get multiple consultations or uncomfortable with, say, a prior consultation? Is that typically an expense to them, or is that done as a free consultation?
100% of our patients that come in for consultations, there is never a fee for anything. So if a patient came in for a consult, there isn't a fee for that. There isn't a fee for a recall. There isn't a fee for even an x-ray.
Wow.
All right. We never charge anything unless we actually need to do some actual work.
And typically that first appointment too, if they're 8 years old, 9 years old, we are taking a Panorex, which allows us to see everything developing underneath the gum tissue in the bone, seeing the adult teeth. Maybe we'll catch a missing tooth, and at least we could start planning for that missing tooth early on.
Okay.
But there's no fees for that until we actually start some active treatment or something like that.
I think it's a nice service for a parent to feel comfortable that, nothing needs to be done at this point. But I also feel like it's a nice service for the dental professionals as well as the speech therapists, because now you guys feel very comfortable sending a patient over, not having to worry about whether or not there's a fee. You know that, hey, I'm not sure if you need anything, but why not go and have a consultation, because there's no downside to it.
Absolutely.
Okay.
If a parent does not have a relationship with an orthodontist, would you recommend that they go for more than one consultation?
You know what? I think that's healthy. I encourage patients to see other orthodontists, to see other opinions, because more than anything, it's a communication thing between myself, Dr. Lucarelli, and the patient. We all want to be on the same page. We're very outward with what needs to be done, how long it's going to take, what we anticipate possible issues along treatment. Communication's key. We want the kids and parents to feel very comfortable within treatment. And typically we're pretty confident that, we could provide the best for them, and hopefully they end up here.
Yeah, and I always think it's a good idea to have more than one set of eyes look at a patient. We're very fortunate that we're able to work together. There's a lot of times where I'll see a consultation and I'll call Joe over and I'll say, hey, what do you think? So even within our own office, there might be more than one opinion or way to treat a patient. So getting more than one consultation kind of makes sense because there's more than one way to treat a patient, and timing and things like that. So having a second opinion or even a third opinion might not be a bad idea. Sometimes it gets a little bit confusing because everybody kind of has their own way of doing things. But I'm sure our parents can kind of see through that and try to look at it the best way to treat their child. But it's a good idea to have more than one opinion.
I may be dating myself in saying this, but I feel like there's definitely more children receiving orthodontic intervention and earlier orthodontic intervention than, say, when I was young. Has there been a paradigm shift in terms of why those early intervention, or we are seeing more individuals receiving or needing orthodonture?
Like I mentioned before, we're pretty conservative. So if there's something that we could correct when kids are 11 or 12, like a little bit of an overbite or some crowding, generally that's common and normal for an 8 or 9-year-old to have that type of issue. They're still growing. Their lower jaw is going to continue to grow even past 11, 12, all the way up until their teenage years. So if we could correct it later on and do everything all in one phase, we both feel that that's the best option for the kids. That's what we want for our kids, and that's how we always treat our patients. There is a lot of younger phase 1 treatment going on. Everybody has a different type of treatment philosophy, but we abide by, if we could do it later on, it's not going to cause any harm, and we can do everything all at once. That's always our first choice.
Excellent.
We do see a lot of patients as second opinions that are, either an orthodontist has recommended a phase 1, or they've actually started a phase 1. And sometimes, Joe and I will take a look and we feel, geez, I really feel as though we could have just waited on this and done this all in one phase of treatment. So I do think that there is a lot of phase 1 being done out there, where I think that if you look at it from a different perspective as an orthodontist and just say, hey, is this something I have to fix now? As opposed to, this is something I can fix now.
Yes.
So if you're looking at it as trying to put the treatment off and looking at it as though that you're providing a better service by doing it in a single phase as opposed to 2 phases, I think that your perspective is a little bit different. You probably treat fewer patients with 2-phase treatment.
A lot of times you could observe the patient too over a 6-month period of time. And within 6 months, not much could happen, whether good or bad. But if it's not getting any worse, we could just continue to observe. And maybe we go a 1.5 years, 2 years, and now we're in full phase treatment. So we avoided having the 2 phases. We got them to a point where they're a little more mature and can handle treatment better. And now for the parents, it's a win-win situation where 1 phase of treatment, finish up, retainers, and they're good for life.
Got it.
You know, a lot of times we do get parents, I would say more and more, they come in, they're a little concerned because, oh, Johnny, his best friend, has braces and they're only in the 2nd grade. And oh my gosh, are we missing the boat on anything?
Yep.
You know, it happens a lot.
Yes.
You know, it's just, we reassure them. And like I said, if it takes 6 months of just observing them, we're happy to do it. And we take it from there.
I'm sure. Now, I know you've kind of gone into this a little bit as well, but besides just being conservative in nature in terms of your treatment, is there a reason that we could be giving parents when they're getting such vastly different opinions when they're going for these multiple consultations? Is it based so much on your philosophies, your education? How does those opinions differ, sometimes greatly?
I think educationally, like Dr. Lucarelli and myself, we went to different schools, but we kind of abide by the same philosophy and we treat the same way, use very similar appliances. Obviously, there's some different nuances between the 2 of us. And I think we learn from one another every day. Different things work better in different people's hands. There are things that I love that other orthodontists would say, oh, I've never had success with it, I'll never use, but I think it works fantastic. So there's a lot of different appliances, there's a lot of different designs on top of having a lot of different philosophies, you know, extracting teeth, early expansion, headgears. There's still a lot of orthodontists that will use headgears to modify growth. And there are times where, you know, we'll use a headgear to correct a class 3 problem, which I think we'll talk about later. But, you know, we haven't used a headgear for the other type of situation in years.
Yes.
You know?
I remember kids walking around with that metal mouth, my peers when I was young. I don't feel like I see that metal mouth anymore with the headgear on, walking around in the schools or in the classroom.
Yeah, I think that it's just really important when a patient does have more than one opinion is to really open the lines of communication. So if we're a second opinion, they've already seen another orthodontist and, you know, they've been told that they need a phase 1 and we're talking to them about, you know, the fact that, you know, we'll just kind of wait. I think that if we can answer their questions well, we can show them on an x-ray why it's not a bad idea to wait, you know, and demonstrate the fact that we'll continue to monitor the patient every 6 months. There's no fee for anything and make sure that nothing's going wrong. I think that most of the time parents feel pretty comfortable with that and that philosophy. And we also allow patients to call us after their consult if they had more questions, or if they did go to a third opinion or had gone to a second opinion after they saw us and they had more questions. They're always welcome to either come back or give us a call.
I know we have total faith in you guys and trust in you guys. I know I sent my nephews even to you, just because I feel that I can trust the recommendations that you guys make, especially with our patients. So especially if they're so vastly different, it may be the reason to say, okay, go. You can need another one like Dr. Lucarelli and Dr. Barisi's opinion before going with, say, an alternate approach or an alternate treatment plan.
As far as palatal expansion goes, do you have criteria for when you would not expand the palate? We've heard some orthodontists tell us that they'd only expand the palate if they're in crossbite. What are your feelings on expansion of the palate?
So when there's a skeletal crossbite, meaning the upper jaw is just too narrow to fit the lower, expansion is the only thing that's going to really solve that issue. It's always a matter of timing, when the best time to do it is, whether 8 or 12. It's just as successful if you do it at 12 at 8. But if there's an issue because there's not enough room for teeth to come in and we're not allowing adult teeth to erupt because we're so narrow and constricted, there's just no room for anything, might be better off to do it earlier. And that's typically what our phase 1 would consist of. I would say probably 90% of our phase 1s are like the situation I just described.
Okay.
Cross bites are easy to pick up. There's different types of cross bites. Bilateral, where, you know, both sides of the upper jaw are inside the lower. That's like, you know, you need a lot of expansion there. There's unilateral cross bites where just one side is off inside the lower and the other side's okay. But that's kind of like the lid on a jar situation, where the way I explain it to parents is the lid always has to be bigger than the jar in order to close the lid. Otherwise, you have to slide one way or the other. And that's kind of what happens in a unilateral crossbite. You see the kids, they kind of bite and you see their chin go off one way. And, that sometimes needs to be corrected early as well, because growth can continue in that direction. Everybody's a little asymmetric. I tell parents that nobody's perfect. They look at my face, they say, look, I'm not symmetric anyway. But, we want to correct that early. And then there are other times where there's no crossbite. However, the lower jaw is compensating, and dental compensation is a big factor that I tell my residents that I teach at Winthrop. Parents, I try to educate them because they say, well, there's no crossbite. Why do we need an expander? The lower jaw is just kind of creeping in and trying to match the upper, but really the teeth should be out here.
Right.
So by correcting the upper, it's actually correcting the lower as well. So not every case there's a physical and visible crossbite, but will still require some expansion.
Yeah. So if the lower jaw is this wide, the upper jaw should be that wide. If the upper jaw is very narrow, all right, you may not develop a crossbite in the back because the lower has kind of started to lean in. So by widening the upper, you create more room for the cuspids to come in, more room for the teeth to develop. But at the same time, you're going to allow for the lower to upright into that. All right, so the lower kind of gets constricted because the upper is excessively constricted. So you don't necessarily need to have a posterior crossbite in order to, need to have a palate expander. When we're evaluating a patient, they really need to have two things to have that phase one palate expander. Number one, we need to be able to diagnose clinically that the upper jaw is narrow. All right, so a lot of times that presents itself as a posterior crossbite. Sometimes it doesn't. And number two, we need to take a panoramic X-ray and confirm that because the upper jaw is narrow, we don't have enough room for everything to grow in. So by doing the expansion, we'll widen the upper jaw, give it the normal width, but more importantly, we're going to provide the room for the cuspids or other teeth to actually be able to come into the mouth as opposed to becoming impacted, and that's the one thing we're trying to avoid.
Okay. Is there ever a time, being that the palate is the floor of the nose, is there ever a time where you are expanding, say, to support airway or to support a patient that may have enlarged tonsils and adenoids, or that their airway is being compromised?
Typically, if we feel that there might be some type of sleep disorder or some adenoid and tonsil issues going on, we refer to the ENT. We have some great ENTs around us. We refer them there. If that's in conjunction with, a maxillary constriction that requires a crossbite, there's no harm in doing it, right? They need it anyway. It could only help.
Yep.
But my conversation with parents is generally not, hey, if we do this, the sleeping disorder is going to go away. They're not going to have sleep apnea, but would it help? Maybe. I don't know, but they need it anyway, so let's do it.
Yes.
There is a physiological limit to how much we can expand, right? Because the upper jaw, especially before they turn 15, 16 and mature, has cartilage in the middle. So we could actually expand orthopedically the two halves of the maxilla, but the lower is set. So you can't overexpand because then the upper will never fit the lower. And now you have a separate issue.
Got it.
But there are times, and we do typically ask parents, if we see a really big maxillary constriction, how's Johnny sleeping at night? Do you hear him snoring? And these are just indications that they may require a referral to an ENT for an evaluation, for a sleep study. And that's life-changing for a lot of kids too.
Yes.
That's something that impacts their overall health, that they should see an ENT for and see a physician or a sleep doctor for.
Absolutely.
There is a lot of data that indicates that by doing an expander at the right time, it can help patients with their sleep and their breathing.
Yes.
We don't do a phase one for that purpose.
Right.
So if a patient doesn't need a palate expander, we wouldn't do a palate expander on a patient just because they're not sleeping well. There's other things that can be done, adenoidectomies, things like that. But I have experienced, and show as well, patients that aren't sleeping well, aren't breathing well, have expansion, all right, where we did a phase one palate expander. And we've widened the maxilla, which gives a patient some more space in the maxillary sinus area, where relatively speaking, the adenoids are relatively smaller than the sinus, so than it was before. So I have seen many patients improve a lot with their sleep and their breathing after having an expander. We don't do it for that reason, but certainly it helps.
During your initial consultation or all of your consultations, are you making note of what you see if the tonsils are impacting the airway? And would that interfere with your course of treatment or the initiation of treatment?
I think we always do a clinical exam on every patient. Every time we see them, any patient that walks through the door gets a full clinical exam. And that's part of it. You know, we're looking at everything inside the oral cavity, right? And sometimes these adenoids and these tonsils smack in the face. You're like, holy, holy boy, how's this kid breathing and swallowing anything at night, right? Or, and we do make note of it. But if it's really significant, that leads us to the questioning that I was talking about before. How are they sleeping? You know, you hear snoring, any issues at school, stuff like that. And then we typically will refer unless there's a need for an expansion or some type of phase 1 or full phase treatment. But yeah, we do make notes of all that stuff, yes.
If a patient or child presents with an underbite, I know we went a little bit into this before. A lot of the times it's waiting until their growth and development is finished so that, and perhaps they'll need a surgery in life. What can be done at a younger age while they are still growing? Is there anything that can be done to kind of help the structure there?
You know, a lot of these kids that have an underbite also have an underlying constriction, like we were talking about, where they need some palate expansion. And a lot of times they wait, and, you know, if the kid is destined to have surgery when they're older, they'll do the whole surgery and do the palate expansion then, or do it under the knife during surgery. We try to do that early. That's something we could avoid, especially at 8, 9, 10, or full phase treatment when they're 11 or 12. Genetics are genetics. And if a kid's going to have a really big prognathic mandible, a really big underbite, there's very little that anyone could do to stop that from happening as they're growing. We could try to compensate for it and bring the upper jaw as far forward as we can, and hopefully try to correct some of what's going on with the growth, and hopefully normalize it so it grows together.
Okay.
But, you know, I never tell parents that, hey, by fixing this underbite at an early age or at, you know, full phase when they're 12 years old, that they're never going to require surgery. For my own kids, or, you know, for parents, I tell them, look, I wouldn't want that. No one wants to have an orthodontic surgery, but let's try to minimize how big the surgery could be if required.
Okay.
You know, and sometimes kids will have an underbite and never choose to fix it, right? I mean,
Yeah, that's true.
there's plenty of patients that we see that they have a little bit of a malocclusion in the back, they have a little bit of an underbite, but they're happy with their profile. So if they could function normally, they look okay, they're not unhappy with anything, they have really nice straight teeth, they never actually even go on to surgery. But we do typically try to treat those things a little earlier and try to normalize the growth at an early age so everything kind of grows together. You know, but sometimes it's winning the battle but losing the war in the end.
Yes. Yeah. Is there an age that you would typically say orthognathic surgery could happen, perhaps for a female versus a male?
In terms of when we would perform the surgery,
Yes.
my safe number is usually 22.
Okay.
Yeah, a lot of kids will do it during college. So
Okay.
even on a female, we would wait until then. Although some females do, you know, since they develop faster, they might choose to do it during high school as opposed to college. But the majority, probably 90% of all of our patients, choose to do it at some point during their college years. But Joe's right. At 22, the growth is complete, and you can really do this safely. But most patients would prefer to probably do it a little earlier than that. As far as you know, that underbite that we see on those 8-year-olds, out of all of the times in which we choose to do a phase 1, that's probably one of the most important ones.
Okay.
And the reason is that we are trying to avoid future surgery. We feel as though the best prognosis to avoid surgery is to do a phase one, maybe at 8 or 9 years old, do as much correction as we can, knowing that they're going to go on to a second phase of treatment when they're 12 or 13. But that we have had really, really nice success with treating those underbites and maxillary width insufficiencies, upper jaws that are small in both width and length, by doing that phase one treatment. So that's a really, really good reason to do early treatment, because you're trying to avoid future surgery. When we do that, we're doing generally a palate expander because we're really working on the upper. We want to make the upper wider, we want to make the upper longer so that it matches the lower. A lot of patients that we're thinking might grow a lot may not grow a lot, and with their lower jaw. And if that's the case, we've now been able to avoid surgery. There are several different ways in which we can make this type of correction. It's generally the same type of palate expander that widens the upper jaw. So that part stays the same. But then we also want to bring the upper jaw forward, all right, so that we get the upper teeth in front of the lower teeth. So there's generally two ways of doing that. One would be something that Joe alluded to before. It's kind of like a face mask. It's a headgear that actually pulls the upper jaw forward. We really don't use that.
Yeah, we moved away from that.
Yeah, it's a very difficult appliance to wear.
Compliance is pretty low.
Yep.
You know, they have to wear it
Yeah.
to sleep. It goes on the front of their face. Kids that toss and turn all night, you know, falls off or it's uncomfortable. Kids can't sleep with.
So the
So
main thing is that Joe's right. It's very hard to wear.
Yeah.
We have found that if we do a palate expander and we put lower braces on and have them wear rubber bands with the expander in, while we're doing that, we've loosened the sutures. The upper jaw can slide forward easier. And the reason why we've had a lot of success with it, probably more success than even a compliant face mask patient, is that they're wearing the rubber bands 24 hours a day, every day, as opposed to wearing them, and nobody's going to wear a face mask to school, right? So they're only wearing that maybe 10 or 12 hours a day if they're doing that. Where rubber bands are really easy. And we use rubber bands to get overjet corrections. We're now using them to make that opposite type of correction. And it's really working great. We've prevented a lot of patients from going on to needing surgery. So treating that particular patient early with a phase one, around 8 years old, is an awesome way to try to mitigate surgery in the future, knowing that that patient will definitely need to have a second phase as well.
Okay. And will there be some type of intervention from the start initiation of phase one up through the correction or orthognathic surgery if that is needed? Are they in appliance the entire time, or do they finish stage one and then go into the second phase, whether it be orthognathic surgery or something else?
Yeah, there's a break in there. So picture a patient getting started with a palate expander, lower braces, some rubber bands for a year and a half.
Okay.
We make our correction. Then we take everything off. We leave them alone, maybe have some retainers just to hold things where they are.
Okay.
Now the patient's 9 and a half. All right, we wait till 12, 13 years old when everything is grown in. Then we do our final correction. We'll hold our correction with permanent retainers and removable retainers. Permanent retainers go on the front teeth, make sure nothing ever shifts. And then removable retainers will kind of, help us maintain the bite correction that we've done. And hopefully that's the only two phases that they'll ever need.
That's fantastic.
Mhm.
That's fantastic. Go ahead, you can do that.
Okay. So we get many referrals regarding a tongue thrust, or patients that you discover have a tongue thrust, oftentimes before ortho, which is, I think we all feel is a great time for that to be discovered. What does your assessment look like to determine if a patient might have a tongue thrust or need an evaluation for a tongue thrust?
neither one of us claim to be speech pathologists.
I don't know, you guys are doing a good job. You're doing a good
That's
job.
why we send them over to you.
We want all of your knowledge and ours. So
Yeah, right.
I'm absorbing it all at this moment.
there are some signs that we see in the occlusion that could lead us to think, hey, this kid might have a tongue thrust. Flared incisors, typically they're sometimes narrow. We always ask them to swallow when we see stuff like that going on. An open bite where the front teeth don't overlap, which is fairly uncommon. Teeth always want to overlap. So something's preventing that from happening. So typically it's the tongue. Ask them to swallow, see this gigantic tongue push forward. That's okay, myofunctional therapy. And that's when we make the referral over to you guys.
Okay.
Yeah, so we see things clinically just with the teeth alone. So, a patient that has a tongue thrust is going to cause their front teeth to flare open, spacing, protrusiveness, open bite. All right. And then we always check to see where the tongue is. Instead of the tongue going up towards the palate, it's coming forward. And the next thing we do is send them over to you, because there are a number of appliances that orthodontists use to help prevent or correct the tongue thrust. I feel as though that they have very limited success. Something like a rake. A rake is something that kind of gets placed on the upper, and it kind of holds the tongue back. Well, if we just did that and didn't use a speech therapist, as soon as we took the rake out, it's kind of like a lion in a cage. You just open the door and it's gonna come out. So really some of the appliances that we use, have some purpose. For instance, maybe we're trying to close down the open bite, and the tongue is in the way of doing that. But if we don't have you guys have speech therapists actually retrain the patient to learn how to properly swallow, no matter what we do, no matter how good of a job we finish this patient with, a great occlusion, great alignment, if that tongue is still popping through, it's going to eventually cause changes that we saw before. All right. So
Even with the retainers.
Yes.
All right.
Yep.
So it needs to be a team approach. We can straighten the teeth and you guys can fix the tongue.
Awesome. What is your advice to a parent that does not ready or not willing, I should say, to go through a myofunctional therapy program? Does that change your approach to treatment for that patient?
I think it's a discussion that we have when we made a referral and there's not been much progress in terms of where their tongue is going. We're going to do the best we can. The teeth will look great, but it's always a retention problem.
Yeah.
How long are we going to be able to keep those teeth the way they are with a muscle like the tongue pushing the teeth forward? Dr. Luke mentioned before, we've used fixed retainers that go on the back of the front teeth and they hold everything in place. But even with those, they're just pushing those and they move together as a unit. So there will be some changes, and we want the best success for our patients and the best results. And in order to get that and have it for life, we really do recommend that they fix the problem. Anything that we do in the office with, tongue reminders, the rake you mentioned before, it's just a Band-Aid on a problem, We're just solving it for that time, but we're not solving it for life.
Excellent.
And, we always express that to parents. Look, that we're going to make the teeth beautiful. We're going to give you every type of retainer we can. We want this to last for life, and it's an investment for life. So in order to keep it for life, we should really have some speech therapy. Without it, there's a higher chance of relapse.
Excellent.
Wonderful.
You want to go? Were you done? We
I
didn't
think
finish all of our
so.
questions? Yeah, I'm not looking now.
I feel like we answered.
I feel like we did too.
Mhm.
Is there anything else that you think would be beneficial to share with parents and our patients regarding orthodontics or orthodontic treatment?
Well, pretty much to kind of recap some of the things that we already talked about.
Okay.
First thing is that, there's not a lot of reasons to, let me start that over again.
Yeah.
Cut,
Cut, edit,
one of those. We're gonna do one of those. Joe was thirsty
Wait a
anyway.
minute, are you drinking high noons over there? Yeah.
You don't know what's in there.
Exactly.
In about 10 minutes.
Yeah, hold on. Yeah, next time we should have some cocktails with this.
All right, so I'll recap.
Okay,
Ready?
recap for us. Ready?
Already.
Okay. Basically, just to kind of recap what we already talked about, that we have a lot of families coming in that may have had other consultations about having a phase one. And we really feel as though that most patients, probably 80% of them, may not need to have a phase one. When they do need a phase one, they really need it for skeletal reasons and that real important reasons, not just to straighten teeth, close space, or unravel crowding. Most patients that have a phase one will go on to having a phase two. It's just, there's no way for us to prevent that from occurring because it's unlikely that all of the rest of the permanent teeth will grow in straight, and we'll want to correct that later on, maybe when they're 12 or 13 years old. Most treatments take about a year for a phase one and about a year and a half for a phase two. It really should stay within that year and a half to 2 year period of time. We see our patients about every 8 weeks. And with those adjustments, we should be able to get everything done within that period of time. In our practice, 100% of our patients get permanent retainers, right? Because of things like even minor tongue thrusts, habits, or just normal shifting, teeth, I guarantee you, will shift if we don't retain them. What I will also say is that the majority of patients don't wear retainers very well. How many 14-year-olds are going to wear a retainer every night through high school and college?
Yes.
Right.
Joe and I believe that we need to retain our cases long-term through college at least. So knowing that teeth will shift and knowing that most patients aren't going to wear retainers, we have the practice of putting permanent retainers in on every one of our patients, 100% of them, both top and bottom. We also give them removal retainers just to back that up. And we leave those retainers in through college, and then we consider removal retainers after that. I think that most families appreciate the fact that we take a lot of effort in making sure that not only we straighten the teeth well, but also come up with a system to make sure that the teeth stay straight afterwards.
Yeah, I mean, a lot of times, kids get out of braces. It's one of the happiest days of their life.
Yeah.
They get handed this like metal retainer and say, okay, wear this full time for the next year.
Yeah.
How many kids are actually doing that?
Yeah,
And then
exactly.
look, it happens to everybody. You get lazy for a couple of days. Now you go to put something in that's slightly uncomfortable. That's motivation to not wear it even more.
Yep.
So, we stress to parents, and even adults have the same type of retention. We stress to them that in the beginning, especially when we've just finished active orthodontic treatment, fixed retention is really important because that's when things are most at liberty to shift on their own. And we back that up because we're a belt and suspenders type of practice that here are really comfortable Essex retainers. They're like Invisalign.
Yes.
And wear those to sleep. And if you really want to preserve your investment and preserve this beautiful result, you can wear that every night to sleep, and it should last years.
And one other thing I think Joe just mentioned about Invisalign is that we are starting to treat a lot more of our adolescent patients with Invisalign, and very successfully. They, our 12 and 13-year-olds, some of them have the type of problem that can be really routinely corrected with Invisalign.
Okay.
Some might not, and they might need to have braces. But I would say better than half of our adolescent patients are candidates for Invisalign. They do enjoy that because now they can eat anything that they want.
Yeah.
They can clean their teeth a lot easier. Take them out, floss, brush. Never having any emergencies. There is a comfort factor. So as long as they wear them, they can work great. There are some patients that would rather just have braces, and that's perfectly fine as well. But we're certainly seeing a lot of success with our adolescent patients wearing Invisalign and getting the results we're looking for.
More and more kids asking for it too.
Yeah. Do you see any difference with regards to success with Invisalign with your tongue thrust patients?
For a patient that has a tongue thrust, we would probably lean more towards more towards metal braces or braces in general,
Okay.
just because they're on 24 hours a day.
Okay.
So that would be kind of a tipping point for us to kind of choose to go towards braces as opposed to Invisalign.
Okay. I have one more question for you. It's totally not on my list of questions for you, but it's always been something I've wondered, is that there's so many kids that play sports and use a mouth guard. Does that have an adverse effect on the bite, pre or post orthodontics, or in general?
We're big advocates of mouth guards. We give every new patient a mouth guard once they start, whether it's Invisalign or braces,
Okay.
or just an appliance like a palate expander.
Okay.
I don't think they wear it enough to actually cause any occlusal changes. You know, if you're wearing it for an hour or two when you played sports, that's great. And prevent any issues to your teeth. Where we do find issues is the kids that watch Steph Curry play basketball all day and they put on the
Yes.
mouth guard instead of actually wearing it. And,
Yeah.
and they come in, they're in their sports gear. They're like, yeah, my brace broke. Well, how did it break? My mouth guard. They're like, oh, I wonder.
Yeah, they're dangling it
yeah.
out of their
Yeah,
mouth.
exactly. Yeah. There's a new oral fixation,
Yeah,
biting and chewing on that.
Yeah, they make special mouth guards for braces patients. They're great. Shock Doctor. Right?
Shock Doctor, mouth guards, 4 braces. And what's nice about it is you don't mold them.
Mhm.
All right. So
Yes.
they have a little track in there for the brackets themselves. So as the teeth are straightening, the mouth guard is not slowing down the movement or interfering with it.
Okay. And then my last question, is there any musical instrument that will have an adverse effect on the bite or occlusion?
He's the musician, so here
Oh,
we
perfect.
go.
Good question. I could see like wind instruments being, you know, kind of protruding the upper front teeth out, you know, because you have to kind of place the reed in between the upper teeth.
Mhm.
Yes. I pretended to play the clarinet at one point in my life, so.
Let's put it this way. Most kids might, play the flute for half an hour a day, 3 times a week.
Yeah.
I don't think an hour and a half is going to make any difference in terms of their bite or their occlusion or
Perfect.
interfering with their orthodontic treatment. If you have, a prodigy that's, practicing 8 hours a day, certainly we'd have to take that into consideration.
Okay, absolutely.
But
We
we
want to
don't
get them
have
some
many of
That's
those.
why I
social
say
outlets
stick
too.
a guitar like myself, and you don't have to worry
That's
about
right.
it.
That's right. This doesn't
Yeah.
affect your bite at all.
Parents will ask us that. And I'm like, I would just go towards something that is not oral. I mean, that you don't require a reed or
Not much. We really
doesn't the
don't.
drums work, the guitar,
Yeah,
piano.
drums, guitar, yeah, go for that.
Yep.
Well, thank you so much. This was wonderful. It's always wonderful to talk with you guys, but even more to know that we're always on the same page and making sure we're relaying information correctly, that you guys are feeling and saying the same things, and vice versa. It's just always nice to work and be co-treating with a whole team of people that are on the same page. And I know that doesn't always happen for us. I'm sure that doesn't happen for you, but it's always been a pleasure. And our patients that come to you are better off for it.
Well,
Oh, thank you.
we appreciate it, and we feel the same way about you guys. You guys do a fantastic job. You're located all around our office, so we're able to send our patients to you guys. And for us to work together on these patients just allows us to have more success together treating our patients.
Agreed.
And thanks for having us, guys. We really
Appreciate
Thank you so much for your
Thank you.
time.